Normally, we have a depolarization along the nose which get conducted, which we call it as no action potential. This no action potential is nothing but the influx of calcium taking place. Once the influx of calcium has taken place, this vesicles will get itself attached to the membrane and releases acetylcholine into that neuromuscular junction. Hope you guys understand, but it's really difficult to understand what I'm saying. If you can follow, right?
Yes, sir.
Okay, we have a nerve part which has vesicles with acetylcholine.
Sir, you're muted.
Am I audible now? Hello?
Yes, sir. Yes, sir. Audible, sir.
Yeah, we have a nerve part. Okay, what we are seeing in the picture is a neuromuscular junction. In the neuromuscular junction, we have two parts. One is within the nerve, and others within the muscle. And between those two, we have a space which is called as a N and J neuromuscular junction. In the nerve part, we have vesicles. These vesicles contain acetylcholine. These acetylcholine are going to get released into that neuromuscular space, that junction. And from the junction, they are going to attach themselves to the receptor, and they're going to stimulate sodium channels in the nerve muscle part, and this opening up of sodium channels will cause depolarization of the muscle, thereby making the muscle to contract. So the depolarization of the nerve is by means of a calcium channel, inward influx of calcium, whereas the depolarization of muscle is by means of influx of sodium. Now today we are going to see about myasthenia gravis. And what is a myasthenia gravis? It is basically a neuromuscular junction disorder, which we're going to deal with now. What is the pathology is that we have autoimmune antibodies against the acetylcholine receptor. Normally, once the acetylcholine is released, after it's getting activates the acetylcholine receptor, it's get degraded by the cholinesterase, which you see as an arrow, right? With arrow without a head. That is the thing which we call as cholinesterase. This cholinesterase will cleave the acetylcholine, thereby stopping its action. Normally, in myasthenia gravis, we have cholinesterase receptor antibodies. These antibodies will go get themselves attached to the receptor, making the receptor unavailable for the acetylcholine to act, so that the muscle won't act. See, the nerve is normal, the muscle is normal, the muscle can able to conduct, the nerve can able to conduct. The disorder is within the receptor, that is within the junction. Hence we call it as it is a neuromuscular junction disorder, which have autoantibodies which act against the receptor located in the muscle end. So thereby preventing the muscle to act. What will it cause? It will cause fatigueness of the muscle, weakness of the muscle. So these autoantibodies won't destroy all the receptors. Some of the amount of receptors will get exposed. The thing is, the number of receptors to act will be decreased because of the autoantibodies action. So hence, the muscles will act, but it will be weak. For example, it will be seen as a ptosis. What is a ptosis? Patient eyelid will droop down, right? He will not be able to lift. When you ask him to able to lift for the first time, he can do it, but he can do it with great difficulty. When you ask him to repeat again, he can't do it, which means if you repetitively stimulate a muscle, it will go for a weakness. So increased weakness when you ask for a repetitive action to perform that muscle, it will be seen. It is because we still have some amount of receptors where no acetylcholine can act. But even these receptors are utilized during the initial action of the muscle. So when you repetitively ask, put the muscle for contraction, it can go for weakness. So the patient will present with, how will you receive a patient? You will receive a patient with weakness and fatigability. And this weakness increases as the day progresses. For example, if a patient wakes up in the morning, he starts his work, he'll be all right in the morning. By afternoon, by evening, he said he feels fatigue, which means the available amount of receptors has been utilized, and by the end of the day, by evening, he can't able to do his work, because now the receptors which has been occupied and some receptors has been destroyed. No more receptors to stimulate the action potential in the muscle. This is how they present. They present with weakness and fatigability. So a patient present with weakness and fatigability, you have to localize the weakness. Where is the weakness? Weakness can be in skeletal muscle as well as in cranial muscles. Cranial muscles in the sense whichever cranial nerves supply. For example, the extraocular muscles. The extraocular muscles are supplied by cranial nerves 3, 4, 6. So patient will have extraocular muscle weakness. What will the patient say? The patient will say he is having diplopia. Patient is having double vision. Why he is having double vision? Because since he has extraocular muscle weakness, which is asymmetric. In right eye, he might have more weakness. In left eye, he can have more weakness. Within the left eye, different muscles can have a different spectrum of weakness. For example, his lateral rectus will have more weakness than the medial rectus. So there will be loss of coordination between the both eyes. So he will have diplopia. This 3, 4, 6. Then what else muscle supplies? We have muscles of larynx. We have muscles of pharynx. So patient will have difficulty in speaking, difficulty in phonation. So there will be a history of voice change. Plus patient will have difficulty in swallowing. We have 9, 10, 11 muscles, right? 9, 10, 11 cranial supplying the pharynx and pharyngeal muscles, right? Glossopharyngeal nerve and the vagus nerve supplying all the muscles of pharynx. So patient will have difficulty in swallowing. Patient will have dysphagia. Then what else patient have? Normally, this laryngeal muscle has to work in order to avoid regurgitation of feeds. Since this action of muscle is lost, patient will have nasal regurgitation as well as regurgitation of feeds into the larynx. Okay, these are cranial muscle weakness. Then what are the other muscles? When come to the limb muscles, patient tend to have proximal limb weakness. Patient was able to climb upstairs. Now he can't able to do so. Or patient have difficulty in climbing stairs. Patient have difficulty in squatting, difficulty to sit down or get up from sitting posture. So patient will have proximal limb weakness. Also he have difficulty in combing, difficulty in having his foot. These are proximal muscle weakness of upper limb. So whenever a patient comes with you with following this complaint of ptosis, diplopia, change in voice, difficulty in swallowing, that is dysphagia, regurgitation of feeds, plus proximal muscle weakness, upper limb in the form of involving difficulty in combing hair, difficulty in having food, lower limb muscle weakness involving difficulty in climbing stairs and difficulty in getting up from sitting position, difficulty in squatting. So these are the symptoms of muscle weakness and fatigue, for which you have to evaluate for a neuromuscular junction weakness. If patient complains with this weakness now, you have to examine muscle also as well as sensory disturbance also, because patient can have CV also. But by ruling out other history, by localizing, once you come to the ward and start presenting cases now, you will localize, right? Cortex, subcortex, capsular lesion, spinal cord lesion, midbrain lesion. Once you start asking history, you will know that those lesions are not there, so that you can work up for a myasthenia gravis, which means a neuromuscular disease. So this is how a neuromuscular disease history will present. Not only antibodies in the pathology, not only antibodies are directed against acetylcholine receptor, we have other antibodies also, and these other antibodies are, see, in the picture you can see nerve cleft, right? This receptor are aggregated. Other 2, 3, 4 receptors are so close. These receptors has to be close. Those green thing I'm showing now. These receptors has to be so close. For these receptors to be in close proximity, we have certain proteins, and those proteins are muscle specific kinase, and another one protein named as, okay, we have another one protein which is named as LRP4, which is a low density lipoprotein receptor related protein, LRP4. We have two other antibodies, two other proteins against which antibodies are produced. The two proteins are muscle specific kinase and low density lipoprotein receptor related protein, that is LRP4. Against these two proteins, autoantibodies are produced. So these autoantibodies will destroy such proteins, and these receptors won't be in close proximity. Again, then it will result in weakness. Okay, clinical feature is how he present with this, and pathology is this. How you diagnose? You can do an ice pack test. Suppose a patient comes with ptosis, you just take a pack of ice and place him within the eye and wait for some time, and then you just remove the ice pack. The ptosis will be reduced. How the ptosis is reduced? Acetylcholinesterase. That's an enzyme, as I said, that in violet color, no, lavender color. That is the acetylcholinesterase enzyme. This acetylcholinesterase enzyme will break the acetylcholine. This acetylcholinesterase enzyme is sensitive to cold. So when exposed to cold, this acetylcholine enzyme will break down. So that excess acetylcholine will be available at the junction to act. Hence, the patient will have improvement in ptosis. So there is some test called as an ice pack test. Then we can do for an autoantibody test. Autoantibody test, it's a lab testing. We can look for anticholinesterase receptor antibody. It is approximately 85% positive in myasthenia gravis. Also, it's positive in ocular myasthenia gravis. See, in myasthenia gravis, we are splitting the patient into ocular myasthenia and generalized myasthenia. What is ocular myasthenia? A patient with only extramuscular weakness comes under ocular myasthenia. There is a weakness involving limb muscles, proximal and distal muscles also have. Then we label them as generalized myasthenia. In ocular myasthenia, this antibody, it will be positive around 50% only. Hence, a patient having antibody negative, you can't say he does not have myasthenia. But if he's positive, he's definitely having a neuromuscular junction disorder, which is myasthenia. If he is negative, there is still a probability of having myasthenia. Then we have other two tests, that is single fiber electromyography and RNS, repetitive nerve stimulation study. We have this repetitive nerve stimulation study in which we repetitively take a single fiber of a muscle and we repetitively stimulate it, and we assess the response. So this response will be in decreasing trend. Okay. And we can use some provocative test. For example, we can give cholinesterase inhibitors. Example is edrophonium. Edrophonium is a cholinesterase inhibitor. When you give it now, it will inhibit the cholinesterase enzyme so that more acetylcholine will be available at the neuromuscular end. Hello. Today's class is over. Actually, I just speak something about myasthenia only. Next time we'll have a live class. In that we will add exercise slide also. Okay. Last class of CNS disease infection has not been taken, right? It will also be added in the class. Next class we can have it as live class. Two of us will come and take. One will take a CNS infectious disease. The other will take the other topic. We will also discuss about the muscle diseases of the muscle also. Since it is what Google Meet class, I don't think it seems so interactive. I think you guys can't understand. We'll teach it in live. Okay.
Yes, sir.
Okay, sir.
Thank you.
Thank you, sir. Thank you.
Thank you.
Sir, good afternoon. Hello, sir.
சொல்லுங்கப்பா.
Yes, sir. I had a doubt, sir. I read that Lambert-Eaton syndrome. The difference is that it doesn't have deep tendon reflex, sir. But how come myasthenia will have deep tendon reflexes, sir?
Actually, reflex is a separate pathway.
Yes.
Okay. Do you think in reflexes neuromuscular junction is involved? It is not so.
Okay.
I'll just send you a pic. I think your rep has my number. I'll send a pic to the rep. You just read that.
Yes.
How does deep tendon reflex work? You are striking a muscle, right?
Yes.
How does this reflex work?
This is the elongation of the tendon, sir. So,
Yeah, this elongation of tendon will cause what to stimulate? What will be stimulated? I'll just send a pic to her. You
yes.
just read that regarding that. It is a physiology. You can refer Genong, I think so. It will be given. See, Lambert-Eaton, when you are assessing Lambert-Eaton, it is the action of muscle itself. When it is myasthenia, it is the problem in the conduction only. If you bypass that conduction, you can contract the muscle. Am I right? Hello?
Yeah, yes, sir.
The thing is, there is a nerve which is innervating a muscle. If I stimulate a nerve, this nerve will get stimulated. It will conducted across the neuromuscular junction and the muscle will contract, right?
Yes, sir.
In deep tendon reflexes, it's not the case. In deep tendon reflex, it is not conducted via that local nerve itself.
Oh, yes, sir. The acetylcholine is
The
not
thing is,
itself.
yeah, that step is bypassed. So in myasthenia gravis, those patients, they'll have deep tendon reflex. I will send the pathway to your rep. She will forward to you.
Okay.
You see it in Genong. If you are interested, if you have marrow, do you have marrow? If any of you have marrow, abdina, marrow or Krishna Kumar sir, do you know Krishna Kumar sir? He is the one teaches in marrow. He has his own book. In that, he have explained about reflexes in neurophysiology. If you have that book, na Krishna Kumar's review, you see that, or that you can see it in Genong also. It is better to read personally because you have to read about Golgi tendon organ,
Yes.
And the annular spiral nerve endings. If you read about these two nerve endings now, you'll came to know about that.
Okay. Yes.
The thing is, the pathway is different. It's not the neuromuscular junction is involved in seeing deep tendon reflexes.
Yes.
Thank you.
Thank you, sir.
Any other doubts? Okay, thank you. I'll leave. மோனிகா, ஐயோ மோனிகான்னு கத்துறேன், உள்ள கிளாஸ்ல 250 பேருக்கு மோனிகான்னு கேட்கு. ஹாய் சார்.